Hello and welcome to Pain Options Education. Sorry for the tears down my face, Tim, of crying after our previous conversation, in a good way. Pain Options Education, this is the place for discussion on topical issues in musculoskeletal pain, for a common sense take on research and evidence, and to help fine-tune your clinical practice. I'm Darren.
Hi Darren, I'm Tim.
Hello Tim, nice to meet you. We're continuing our discussion around pain sensitivity, and today we're on to the big one, maybe. Implications of pain sensitivity for management. So it is a big topic, and you can't take it out of context of the management of a person as a person, but we will try and focus on the pain sensitivity aspects of that. But that's never going to be complete, but we'll give it a go.
Yeah, I am. Again, we aren't the experts on this. We've seen lots of it. We've thought lots about it, had discussions with people. It's definitely an evolving area. So don't believe everything we say. We agree with ourselves most of the time.
I believe us.
Yeah. But hopefully there's some useful, practical bits in here.
But I guess we would also reserve the right to change our minds later. Yes. So my favourite management strategy for these people is when I get them in full body widespread pain is I tell that I'm booked up and I book them into you. Did you notice that?
I had noticed a bit of a trend, but I have a similar strategy.
Yeah, so I thought they kept boomeranging around. But I guess the point of that is like it's no shame in having difficulty managing these people.
No.
And if you need help, ask for help. And we would, discuss these kind of patients all the time. Just discussing it, often makes you think of something that you haven't thought of. So that would be a big tidbit, I think. All right, so where are we starting? Probably with our definition of pain sensitivity. Funny that. Pain sensitivity in the clinical context can be considered a term used to encompass the phenomena that some people's experience and perception of pain is enhanced beyond that of others. Now the challenge is trying to manage that.
Exactly. So if we see someone with enhanced responses to pain, how do we deal with that?
Yeah, exactly. I'm so happy that I finally got an umbrella in, with all these slides. You need to have an umbrella, but it's taken this long.
Yeah. Good timing though, isn't it?
It is, with the rainy weather here today. Well, like once in a decade storm, isn't it, Tim?
Apparently.
So look here, I just wanted to mention musculoskeletal physiotherapy involves a lot of different things, not just musculoskeletal physiotherapy, but conservative management by any healthcare practitioner. But they're probably the key tools are the top three around education, manual therapy, and exercise. I've thrown modalities in there in there as well. But one of the things, well, you won't find any modality machines in our clinic. That's how important it is. But I thought I'd put it in there anyway, because it might be important to others, Tim.
It may be.
And really this is just to say, well, look, we have all these different kind of interventions and they can affect a person on a neurophysiological level.
Well, that and other levels as well.
Yes.
So I guess if we think back to earlier patients when we were younger physios, and if you think about now if you've identified pain sensitivity in a patient, you would note that changing, and it might change in response to a whole range of different things.
Yep.
In the past, some of these people we may have successfully treated using some of those interventions you've listed there, but they got better for completely different reasons than what we thought they did.
Yeah.
And that's, just part of our knowledge evolving in this area.
And probably the other thing that makes me think of is we've said earlier that pain sensitivity is a predictor of poorer outcome from surgery, but you and I have both had instances where people have had surgery. We've thought, this might not be the best idea, but actually that's taken away a driver of pain sensitivity.
Yeah,
for
correct.
Some. Yeah.
So some of them have had a great result,
Yeah.
which you wouldn't have predicted, but it shows you, like we talked about in the last session, there's many things that contribute to pain sensitivity.
Yes.
And at times some of those will be pathology, but obviously surgery doesn't just address pathology.
Correct.
There's a whole range of other influences there.
Yeah.
But for the same reason that there'd be people that are a high degree of pain sensitivity that ultimately do respond well to manual therapy. That said, they're probably the exceptions rather than the rules. And I don't think we can continue to apply a typical management approach for people with increased pain sensitivity as a starting point. And if we do, we'd certainly be wanting to monitor and track it, because if they ain't getting better, or in fact they're getting worse, time for a rethink from there.
Yeah, it is. I'm kind of thinking now of the numbers needed to treat scenario, and if particularly around medications, that concept is, and we know if you and I had a headache, one of us took Panadol, one of us would get better because the numbers needed to treat for headaches with Panadol is 2.
Yep.
For the medications for pain pain sensitivity, the numbers needed to treat starts to blow out, and there might be 6, 7, 8 people for one to have a positive effect.
Yeah, I think it's probably even more.
Yeah.
I mean, some of those centrally acting medications for specific neuropathic pain diagnoses, at best the numbers need to treat are around 6 or so.
And numbers needed to treat is a tricky concept because it doesn't include papers that don't show an effect. It only includes those that do, so that expands it out as well. And then it doesn't talk about the numbers needed to harm, or the side effects from these medications are high. So you can, that could be levelled as a criticism against medication, but the numbers needed to treat for education, manual therapy, or exercise in the case of pain sensitivity might not be much different.
Yeah, we don't know. It hasn't been tested, really, has it?
Yeah. So, so what's next? So pain sensitivity can modify the response to treatment. So roughly that's what we were just talking about a little bit there. But that's why the clinician needs to be aware that the person's pain sensitive, in my mind, that what they're going to now apply to this person in some manner might not work the way it would in someone that wasn't so pain sensitive.
Agreed. So could we say at a minimum, it is our responsibility to be aware of increased pain sensitivity in people? At a minimum, to at least be aware of it at the starting point. We may continue down our usual path of treatment. Hopefully not if there's a clearer alternate path, but we might continue down that path. But if after 1 or 2 or 3 sessions things aren't proceeding as expected, time to reappraise and change direction or on refer.
Yeah, I think if you're observant, but in 3 sessions you'll know.
Yeah, at least get a change in that time frame.
Yeah. So first up, we've got here some general considerations before we get into the specifics of different modalities of treatment, if you want to, modalities of management, if you want to call it that. These are just kind of some global statements, so they might touch a bit on specifics, but we'll leave the specifics mostly to the next few slides after this one. The first kind of construct or concept there is facilitating pain sensitivity begets continued pain sensitivity, and you used that great word that started with E. What was it? Enhances or
efficiency.
Yeah, efficiency. That's the word. Bloody pain scientist you are.
Yeah.
So I mean, I think it's a reasonably good statement, really.
Yeah, it's a known phenomenon that the system does get more efficient, and it takes less of a stimulus to trigger that response. In this instance, we're talking about pain. And if we're doing treatments that are facilitating that, we really need to think carefully about that. Yeah.
And it leads to the next point, which is balancing the benefits of movement against this concept of not wanting to over-facilitate pain sensitivity and enhancing that response and increasing the efficiency of it. That's a difficult balance sometimes.
Well, it is, particularly those people that are already really sore, but they've had a good shot at resting already and they've proven that ain't working.
Yeah.
So time for something different.
Yeah.
But I think we both agree that it's a matter of how you get people to proceed forward from there, and activity is what they need. It's just a matter of how that's done and the context and understanding around that.
What have we got next? Passive management and avoidance of activity are unlikely to be helpful. Yeah, I'm pretty comfortable with that statement as well. I mean, we see these people often that have had a lot of passive treatments and it's not going anywhere. It's the old, we mentioned it before, where they'll go to the therapist, they'll feel bad after that for 2 days, and then they'll feel better, but actually they don't feel better. They're just back to their baseline, but they have this belief that will get them better.
Or you see some that will report benefit from the passive treatment, and maybe there is a bit of benefit, but it's only a bit, and there's no overall net change.
Oh, yes.
And
yes, that's
the patient's happy with the therapist, they're happy with the treatment, and
Yeah.
they want to continue that. But if that treatment is actually facilitating this ongoing sensitivity, we really have to question whether that should be continued.
Yeah, and you make a good point about the patient that, oh yeah, I get benefit for that, I feel a lot better. And you go, well, how long for? Oh, well, by the time I get out to my car, I'm sore again. Or,
That's called the driveway guarantee.
Yeah. Like that. We should put a sign up outside our clinic for that. I can understand that. When you're in pain all the time, any break from it could be, perceived as helpful.
And we've seen that where people have had procedures and surgeries and a range of different things applied that have made them worse.
Yeah.
But they're okay because at least that person's tried something to help them, which is it's a really difficult circumstance that some of these people are stuck in.
Yeah, and stuck's the issue here. If you're stuck on passive management and avoidance, that's not going to get you anywhere. Patient understanding and active engagement is critical, and we spent time discussing ways in which this can inform the patient, particularly in terms of reflective questioning during the physical examination. But if you can't get the patient to understand this, it's going to be difficult.
Yeah, I think you've almost got no chance if you can't get them to understand it. You have to be careful of what we're saying or meaning by that, because understanding doesn't mean you need to turn them into pain scientists, which is a big error, I think, around pain education. We use the physical examination, as we've demonstrated in the videos, to help facilitate a conversation around showing them that their system's sensitive, but then that really just segues into, well, what does that mean?
Yeah.
It depends for that person. So understanding pain sensitisation, and you talked about a previous example of a woman with headaches who was highly stressed. For her understanding might be, my stress is the main driver of my headache. She might not understand any pain science at all.
Yeah.
Obviously, you'll have others that they want the detail. You can send them scientific papers and they'll be into that side of it. So education and understanding is very individualised, and the direction that takes can be highly variable.
Yeah, and if the person isn't going to take some responsibility for their own care and continue kind of seeking passive, alternatives and avoidance kind of behaviours and passive coping, you're going to struggle with these people as well, aren't you?
Yes, you are, but often it's about timing as well.
Yeah.
So they're not in a position necessarily at the time they've seen you to take that on board, but sometimes that does sow a seed and someone else mentions that again at some other time and they're in a better place to take that on. So it still can be helpful, but if they're not buying in at that time, the odds of change at that time are low.
Yes, whenever I can't get somebody better, it's all about readiness for change, and they're clearly not ready. A personally meaningful management plan, and it comes a bit back to around education, which we'll come to in a moment, but I'm not certain generic education or generic approaches are the best for these people, for anyone really, but I think making something personally meaningful is very, very important for these people.
Yeah, the research hasn't been great in showing the effect of generic education for lots of different conditions. So it's the same with anything in life. If it's got meaning and purpose relevant to ourselves, then we're way more likely to engage in it.
Yeah. Consistent team-based approach in the delivery of care. Goes without saying.
I want to expand, but I won't expand.
I'll expand a little. I think even this can be around perception of the person as well, or their health literacy. So I might say you're pain sensitive. They might go to the GP and they say, oh, you've got neuropathic pain, and they might go to the psychologist who says you're centrally sensitised. Well, actually, you got three people that are telling this person the same thing, just in different language. So even just something simple like that, consistency around language is massively important. And so you need a team that's speaking from the same playbook, really.
Agreed.
Holistic biopsychosocial approach. I mean, we've said this many times, but it's a whole person approach.
It is, and people nod and agree, and their eyes glaze over. But then they really do need to step back and examine how they are approaching this, because we see we're involved in reviews of complex cases a lot of the time, and then we're either having health practitioners sitting in or communicating with them, and we might list out recommendations similar to what we're talking around now as an approach, and the patient has previously had an approach that isn't aligned with that at all. It's been very focused on pathology or one domain. But the therapist will often come back and say, yeah, that's exactly what I'm doing. So it's very important that we do reflect on, what our practice is and what that looks like, because it's easier to try and merge. I educate all my patients, for example. It's easier to merge that into your clinical practice to say what I'm doing is broadly okay. But reflection on that, I guess, with the lens of feedback from other people is also important.
Yeah, yes, it is. And I think, medicine in general, physiotherapy in particular, has become very good at recognising musculoskeletal disorders are biopsychosocial in nature. But the missing part of that is integrating all of that stuff and seeing how it interrelates, and then building a management plan around that. That's why we have the clinical translation, musculoskeletal clinical translation framework, and you can tune into our other series on that for more information about kind of integrating this stuff into treatment. But that it is still a challenge for clinicians to operate in that way. And
we see that in educating clinicians, but there seems to be this dichotomy where people go one way or the other, and suddenly everyone's got a strong psychosocial element to their presentation, and that needs to be addressed. And there's many times that's not the case either. So similar to pain sensitivity, the biopsychosocial approach has bio in it, and psycho and social, and people fit variably along that spectrum.
Yeah, correct, appropriate organisational model of care and care settings. So I guess, for instance, we could say, like in a workers' comp setting, that from a medico-legal perspective, might be designed around a biomedical view of pain, could make it difficult to manage these people.
Yeah, we obviously can see many examples of that, but different healthcare settings, different health literacy levels, different parts of the world, different cultural responses around pain as well will dictate what's appropriate to be either provided as treatment or education or engaging other family members or not. So there's many different parts to that, but the setting that we're working under will influence how we approach this and potentially how we can deliver different management.
So we'll move on to the management section now, I think. We'll go through a list of some different things. I think we should say that this is a very pragmatic kind of design of talking about management. The research in this area is new, emerging. The research around identification of these problems is a bit more mature. So really, it's a very pragmatic kind of approach from us here around as our tagline, it's a common sense take on current research and evidence to try and make some sense of this for clinicians in terms of assisting these people. I'm sure it will develop into the future, but here's where we sit. So what have we got here? Some unhelpful strategies. Managing the presentation like there is low pain sensitivity, and that's kind of, we've already spoken around that. If you continue to facilitate pain sensitivity, you'll probably get more of it.
Yep, and that can be with manual treatments, exercise, anything.
Anything.
Yep.
Limited role for passive hands-on manual treatments, and we have spoken around that a little, but the mechanism of manual therapy is so strongly neurophysiological, in my opinion. And that's from the direct, let's say direct neurophysiological effects, and then also the placebo effects, the non-specific, it's the specific and non-specific effects is the words I'm looking for. But all of that works on a neurophysiological level. But in some ways, those systems that we rely on for that are broken in these people with high pain sensitivity.
Yeah, they're not. Or if they're broken, they're fixable.
Yes. Well, yes, they're still there. Broken might not be the best word, but it's a word that patients can relate to, that something's broken and you need to mend it.
Mm-hmm.
So I think we'd agree that a short burst of passive kind of treatments might be worthwhile, but you need to put a very definitive period of time around that.
Yeah, and in most instances, it's not even worthwhile.
Yeah, agree.
There's plenty of these patients.
I was trying to be generous.
There's plenty of these patients where I wouldn't use therapy at all.
Yeah.
There's some where you may try it, and I've seen some positive results around that, but as you say, 2 or 3 or 4 sessions, look for measurable, sustained change. If not, time to move on.
Yeah. I did see a case study of a physiotherapist applying grade 1 mobilisation on someone that had allodynia.
Excellent.
Yes. At a national conference, mind you. Pacing to push through pain. So this is the difficult balancing one in terms of getting the person active, but not pushing them so hard that they're going to, excessively provoke their symptoms. Maybe doing, the natural pathway of that's a boom-bust kind of pacing pattern. But a therapist can feed into that easily. And I can think of many people that are, pain sensitive, thrown in the gym and it's destroyed them.
Mm-hmm. Yeah, where it's an unhelpful strategy. So pacing is a very valid strategy, but where it's unhelpful is ignoring the pain and continuing to build despite the pain continuing to escalate.
Yeah. So I think strategies, that's an unhelpful strategy, but certainly... I was going to go into the helpful, which would be next. But while we're on pacing, little bits across the day are likely to be more tolerated than large chunks, do you think?
Yeah, but there's lots of specific sort of individual reasons how you would go about that.
Yeah. Blaming pathology or lack thereof. So it may be that on a scan of a low back there is, let's say, a minor disc bulge. But this person has pain in their back, but their whole leg is painful. They've got pins and needles in both feet. So blaming pathology or trying to relate those symptoms to pathology in that situation is not going to help you much.
No, it's very unhelpful.
Yes. And the opposite of that is same person's got back pain, pins and needles in both legs, all of both legs and the feet, and pain in the heels on both feet. Headaches as well, let's say, and they have a scan and it's crystal clear. So the treating person says, well, your scans are fine.
Yeah, there's nothing wrong with you.
There's nothing wrong with you.
That's equally unhelpful.
Equally unhelpful.
Yep.
Not addressing beliefs and expectations could be a big mistake for these people.
Yeah, and it goes both ways. So listening to what they want or what they're expecting and what they believe is going on. And we talked about rolling with resistance in a previous session. So that's where the physical examination and then tying it back to their story and making sense of it for the person is, to me, the key around that. But that has to be delivered in the context of what they think is going on. If they say, I think something's really sensitive and I don't think there's anything structurally damaged, that's easy. When they're in the opposite thought process, that's where it's much more challenging.
Yeah, I think of my girl I spoke to you earlier about around the headaches and the sensitive head, and that changed quickly. Like it was a couple of weeks literally, and that sensitivity had gone, and maybe you could theorise there. Well, and it was indeed stress that was driving that. So there's some kind of wind up of the system related to the state trait. Yeah. state of the person.
Yeah.
In other circumstances, someone might have had pain for a long time. There's these theoretical constructs of plastic changes in the nervous system, not related to process, but related to structure, with their sprouting of neurons, etc., that could lead to structural changes that continue to facilitate pain. Maybe those things would take longer.
Potentially, but we've got no way of measuring or knowing that as clinicians. So I think...
So I guess the point is that it is hard to, know where this is going to go, because in the end you want to try and make sure the patient's beliefs and expectations align to some realistic path forwards.
Yeah.
And it might not be easy.
No, but I think it is still fair to set time frames and shorter term goals around what might change. That might not be directly to do with pain, it might be more to do around function, for example. And if you're not creating change in those, you again have to step back and question where you're heading. Yeah.
Okay, good. So any other big unhelpfuls you can think of? So flipping over to helpful things. So the first one we've got is give a diagnosis and education around that and contributing factors and what's going on.
Yeah, so that's just matching the story. So explaining that they've got increased pain sensitivity is only one part of that. Making sense of that from their story as to why or what might be driving that, that's the bit that really makes the difference in my experience.
Yeah. And I think the educative process of the physical examination is so highly valuable here. We spoke about that in the episode on assessment, but if you can tell a person they're sensitive and their nervous system's wound up, that's fine. But if you show them that, then it's a completely different game.
And the third bit of power is if you can show them they're sensitive, but then if you can look at modifying if there's issues with how they're moving and functioning and improve that with certain ways. So for certain people, they've got these automatic guarding behaviours when there's increased pain sensitivity. So for some of those, if you can relax that off and the tissues don't become as sensitive with movement or function, that's, again, additive power, that being able to experience that.
And I think delivery of the diagnosis and education in a confident manner is important. And if you're not confident, find someone that can give a supported message or back up or give credence to your own thoughts is helpful.
Yeah, I can remember being a more junior physio and thinking I'd worked out what was going on and got the patient to be reviewed by a senior or specialist physio, and I'm sure they told them exactly what I'd just said, but it seemed to work a whole heap better.
Yes.
So that's probably around the confidence and the presentation of that.
Yeah. And also on the way that you deliver that information. Like, I'll have physiotherapists and others come in with me all the time, and it's always clear in my mind when the patient leaves and they go, "Oh, I've been saying that." And I said, "Well, did you write it down for them?" So simple things like writing it down are important.
Agreed.
Yeah. All right, now I'll give you my 3-hour pain lecture in about 1 minute here.
Okay, go.
I still get paid for 3 hours, don't I?
Sure.
Oh, good. So we've done this assessment on you, Tim, and you realise that we looked at your light touch sensitivity, and that was very sensitive. And when we put the sharp on there, that was different to other areas of your body, and the same with the ice. So you understand that you're sensitised. That made sense to you, or you at least recognise that?
I could really see that was different to another part.
Yeah. So this is what I kind of want to tell you this means. So at the moment, my system's not wound up. It's not sensitive. I don't have pain. But let's say I did the same thing, fell over, hurt my back. Then my pain system would more or less wake up, and it would have a couple of jobs to do. One would be to maybe make me rest, so I can just rest and let it calm down. And the other one would be to tell my body to start the healing processes. And then, 90% of the time, within 6 to 12 weeks, my body's going to heal itself. The pain system can say, okay, my job's done, and just wind back down. For you, unfortunately, your pain system hasn't wound down. It's still staying wound up. Does that make sense?
Yeah, it does, Darren.
Yeah. And then you've told me before, well, you're not sleeping well. Well, when you're not sleeping, you don't give your system a chance to wind down.
Well, that makes sense.
And you told me you're feeling really depressed. You look really depressed. And we know that those things like depression and stress, they really wind your system back up. So you've got this whole imbalance of things that are feeding into this, your system being wound up.
That's good. I like it.
Good.
Yeah.
So I think that was worth 3 hours of pain.
Yeah. I'll pay on the way out.
Yeah. So look, it might not be the perfect way. People might not agree with that, but the point is, it can be simple. And
Yeah. I use very little pain science in terms of terminology or how the system works so much. Some people are aligned to that thinking and they really want to know the details, which is fine. But there's a greater proportion that don't, and they just need some logic around it. And as you said, if you've listened to their story and they've actually given you that information, you're not making it up.
No.
You're just cheating because you're using what they've told
This
you.
is paraphrasing. It's not.
To work out what's wrong and give that back to them. It's funny when I say something and then you say it back to me and I agree with you.
Yeah, that is good. Yeah. You going to give me a pay rise, Tim?
No.
I thought you said that.
No.
I phrased it wrong, didn't I?
Yes.
I'll try again later. All right. Anything else on education?
No, but careful pacing, I like that.
Yeah, careful pacing. Tricky. And again, another simple analogy, but too much is bad for you and too little, but you might have an in-between that's this big.
Yeah.
The person with pain sensitivity, their in-between might be this big.
Yeah. The thing we call careful pacing, that doesn't mean we always approach the person carefully.
Yeah.
So we might be careful in how we ask or prescribe what we want that person to do, but for some of them, we might be really sort of pushy or encouraging for them to really get going because we've judged for them that there's a lot more reserve in the system than they've been using. So they're often the very avoidant people.
Yeah.
Whereas the boom busters, like you talked about previously, they're the opposite. They're the ones where you need to give them that ceiling and be quite careful at their rate of progression.
Yeah.
When we talk about people that are endurance copers or people that are just happy to push on regardless and they're keeping their system sensitive, you almost need to take the opposite and put the reins on them and only let them slowly progress.
Yeah.
Versus the avoidant ones, you want to give them confidence, but you've got to hit that band right. Otherwise, you've got that same issue of them flaring up and losing confidence. So again, it's a real skill. I get it right some of the time. We work with other staff who are certainly better than me at doing that at times as well. And different people function better with different approaches. And that's also important to remember.
Yeah. And look, I get the starting point wrong sometimes, so it's not easy. I think I was thinking of two things, and they'll come back to me later. Totally gone. Oh well.
But I think you have to be open to getting that wrong.
Yeah. And
not blaming the patient, but saying this is a guide, but I tend to hand over responsibility to them to say, look, this is what we need, this is what we're aiming for. I kind of want you to work out the exact amounts, but we'll check in with you and we'll coach you around that.
Yeah.
But it's useless if the person is just passively following what's being told. They've got to understand this and work out that trajectory for themselves to some degree.
Thanks, I remembered my two things.
That's all right. That was just a filler.
Yeah. Quick, keep them in my mind. One is the patient that comes in and they're clearly getting worse. And I think it's okay to have a goal there that we just need to stabilise your baseline. And we're just going to take 4 weeks to do that.
Yep.
Don't worry about progression. Let's just stabilise you. I think that can be quite relevant for some of these people.
Yep.
The other one I'm kind of playing with a bit, and I've got no basis for this, but it's around, with tendon pain, we will say, okay, well, you can stir your pain up as long as it's not over 5 out of 10, the research would say, and as long as that's better within roughly 12, 24 hours. Does that kind of approach work with people like this, particularly the boom busters?
Well, the classic you can think of is if they've got non-mechanical constant pain and their starting pain's already
the number doesn't
5 out of 10.
The number doesn't. You've got to adjust the number, but is there a use in kind of determining how long the pain increase after an activity lasts for?
Yes.
Yeah.
Definitely. I often say to people, now that we've worked out that your main issue is increased pain sensitivity, I actually don't care about your pain.
Yes.
Now, you've got to be careful saying that.
Yeah.
But what I'm meaning by that is I'm not worried about your pain, in that your pain isn't a signal of tissue damage. So if you do too much and flare it up, that tells you that sensitisation response or efficiency is occurring and you're getting more pain.
Yep.
That's fine, and everyone's got different capacity to tolerate that.
Yeah.
So what you might get people to do is note how long you can do an activity for and note how long it takes to calm down, and that might help you judge how frequently you do it. But you often have to, I guess, help people set what's acceptable, because some people get pain after a few minutes and it takes a long time to settle down, but it's not actually very disabling pain. They're just more worried about it.
Yeah.
So there's a whole lot of different ifs, buts and maybes around that, I guess, which comes with experience, but comes with working with the person.
Yeah.
Yeah.
Good.
I don't even know if that answered your question.
Yeah, no, I feel it did, in terms of, you have to get buy-in and a strategy that will progress the person, and take into account those things, but put them in the context of bothersomeness in particular. And I think what you're alluding to is around kind of maybe in a way making the person feel safe to do something despite the experience of pain.
Correct.
Okay, breathing and relaxing.
It's good for most of us.
Yes.
Yeah. And people in pain, particularly with increased pain sensitivity, they don't even know they're not doing that.
Yeah.
So we'll often see them breath holding or tensing, and often you can do those simple behaviour experiments of getting them to relax and breathe and move.
Yeah.
Sometimes that's too much, and just getting them to lie down and breathe can be very powerful. So very helpful strategy. There's lots of different ways of going about that.
Yeah.
And it's not just physios, obviously psychologists use it a lot. There's lots of meditation, yoga, relaxation apps. There's lots of different angles in on that. But that's one tool. That doesn't fix everything. No. You've got to get people functioning again.
Yeah. Yep. General exercise. So in essence, I think we'd agree that general exercise is an important counter to try and wind the system down.
Yes. Almost every person gets prescribed that. There would be a few exceptions on very odd occasion, but we're trying to increase functional capacity here. So we're trying to get people to exercise. It's just a matter of what mode and how often and so on. That will depend on each person. Yeah.
Yeah, massively important, not only for its effect on winding down the system, but its effect on comorbidities such as poor sleep and poor mood.
Yeah. And
it's almost a non-negotiable aspect of it, really, isn't it?
Yeah, agreed.
In the mechanisms that we're all familiar with in terms of the endorphin release from exercise to reduce pain sensitivity at a neurophysiological level, and the hypoalgesic effect of exercise, again using that word broken, but that can be broken in some people. So again, it's around the pacing and just doing it in a careful way, and gradually exposing them and building it up in a planned manner.
Agreed.
Functional movement that normalises aberrant movement behaviours. So I think you touched on this a little bit with breathing, but people start to move in funny ways, don't they?
Yeah. Spoke with someone the other day about the old Monty Python Ministry of Silly Walks or Funny Walks, I think it is. So people often are doing things without realising, because we do have those behavioural responses to pain, which are initially often helpful or protective, but then they can be unhelpful and maladaptive or aberrant.
Yeah.
And that might be contributing to their pain. So that's where we've talked about those functional movement or behaviour experiments where you go, hang on, let's get you moving differently. So for some people, they may avoid loading a sore leg because of their pain, but if you get them to understand about the lack of pathology, for example, and then slowly engage them in loading their leg more normally, maybe that makes them feel better, not worse.
Yeah.
The good thing about that, it's safe to do, other than the biggest risk is you might give them a short-term pain flare-up. But if you're testing it and they're getting a positive symptom response, as in they're less sore than they would normally be, then that's a very safe way of graded exposure back to normal function.
Yeah. And harping back to breathing and relaxation, I mean, they're the easy go-to critical kind of things that you can quickly make a difference with some people, even those that are quite sensitive around that.
Yeah. And do you find that you have a standard approach to types of exercises you do with that, or how would that look for you?
How would that look for me? I mean, you go off the functional aggravating activities, but often, I guess it depends also on the area of symptoms, does it? But my mind goes straight to sit to stand.
Yeah.
And how would I decide? I think, it's just your general observation of the patient and how they're moving and what they're doing, then understanding what their aggravating activities, and I guess you do go. I just go for one where you think you might get a win.
Yeah. I think it does depend. Some people sit to stand's way too complex.
Yeah, exactly.
And it might be just shifting a little bit of weight across, or relaxing and lying. But so it's again individualised, but it's directed at function.
Yeah.
And their functional impairments.
Yeah. Graded motor imagery is an interesting one, and one we think about probably more than we ought to. In essence, graded motor imagery, I mean, people are familiar with specific kind of aspects of that, particularly around side to side.
So the laterality.
Laterality, yes, thank you. But I think, conceptually aligned to that is body scanning, which I know you're really good at, and also visualization, particularly visualization of functional tasks or movements. It's very interesting when you get someone that's highly pain sensitized. You ask them to visualize, getting up from a chair, and not only can they not visualize themselves doing it normally, they actually experienced increased pain during that visualization. Goes a long way to show how sensitized the entire system is.
Yeah, I mean, we've explored this a lot just on a case-by-case basis with patients. We have done a little bit of research around this. Impairments in body perception aren't unique at all to people with increased pain sensitisation. Anecdotally, we probably see it more often in that group, and as we mentioned in an earlier talk, for some of these people, getting them to move is too hard or it's too challenging. CRPS would be an example of that, but many different, more localised pain presentations. I can think of people with localised knee pain where this is relevant as well, where you can start trying to normalise their body perception as a starting point, because there is an altered response to pain that has become unhelpful, and that response is not just in the level of pain or the somatosensory response, but it's our perception or expectations around pain as well. So it's just another part of the system that we could have an angle in at to help desensitise, or, like I say to people, to normalise your perception. So if you're perceiving and getting normal signals back from an area, that can be helpful in getting a more true response rather than this unhelpful pain sensitisation.
I think it's important to try and align, to have some assessment findings that lead to this. Like, many people I've seen given specific aspects of graded motor imagery as part of their program with no assessment to underlie the basis for that. And a classic one, I can remember, this guy had pain sensitivity in his foot. It was clearly post-surgery and aligned to a specific nerve distribution. So in fact, it was probably neuropathic pain that was caused after surgery as an unfortunate side effect of that. And he'd been given the, foot kind of different positions, left to right kind of work to do.
So the laterality training.
And a mirror box, I think. But actually, if you assessed him on his body scan and on that very laterality measure, he was fine. Yeah. So it just doesn't make sense. So I think we see that stuff given out generically.
It's the same as giving range of motion exercises for full range, or strength exercises where there's no strength deficit. It's got to be a clear impairment.
Though then kind of in kind of flip to that is, like, athletes use visualization of tasks to increase performance. So if there was one that I would say, well, you don't need a deficit in, it would be visualization of task rather than those other specific modalities, given athletes do use that for performance enhancement.
So you're saying someone, for example, with pain with sit to stand, visualizing normal sit to stand as part of that rehabilitation process? Is that an example of that?
potentially.
Yeah.
And I would also, and I have no proof of this at all, maybe we'll find someone that one day, but I think integrating imagery kind of stuff into movement is the way to go. So, yeah, yours is a good example, like, or maybe they're squatting, and they can only squat a quarter of the way, then in their mind, go the rest of the way. So you're actually doing and thinking about it at the same time.
And there's evidence around that. Imagined exercises have shown strength changes, so there is some science behind that, but not proven in specifically what we're talking about here.
Yeah, and not so much the combination of actually doing and thinking at the same time. I haven't seen anything on that. So if you want to do a PhD, come and email us, and we can think about that one. Phew, all right. Anything else on those helpful strategies there?
No, I think we've said plenty.
Yeah, I think that's the nuts and bolts of musculoskeletal physiotherapy management.
Well, maybe one thing, we've listed 1, 2, 3, 6 of those there.
Yeah.
If you saw a person and you were starting management, how many on average of those 6 might you prescribe within the first session or two? As part
Well,
of
the
their
first one would
management?
go without. The first one happens, like diagnosis and education. So that's without. So that, I mean, if there's only 2, that's the number one. Yeah, I mean, there's a lot of overlap between pacing and breathing and relaxing and general exercise for me. So
you might say
something
3 or 4 or 5 of those you might use to some degree.
Yeah, and then I mean the breathing and stuff we've put to function as well.
Yeah.
So yeah, I might go for an overall approach that uses multiple of those concepts,
but not in the same way with each person.
No.
Yeah.
No.
That's the interesting bit, though, isn't it? So it stops it being boring because you're not prescribing the same stuff every time.
Yeah.
All right. Good.
Okay. Great. And look, just some other more broader global things. I mean, they're in the realm of musculoskeletal physiotherapists or musculoskeletal practitioners, but just put aside because they're a little bit beyond the scope what we're trying to talk about in this pain sensitivity series. Multidisciplinary team approach. So we've kind of actually spoken about that more generally, so that one's probably fine. Medication that specifically targets pain sensitivity might be a good idea. It's not our job to prescribe that, but alerting the person with pain sensitivity to any anomalies in their medication prescription that they can then discuss with their medical provider is a good way to go.
Yeah. I use the Pain Health website quite a bit because there's good evidence-informed information there, and I often give them as information sheets and say this is something you might like to discuss with your doctor.
Yeah.
But then on top of that, there's other medications around, for example, sleep as well, because some of these help pain and sleep, so you could be ticking multiple boxes with some of those. Yeah.
And so we'll jump to sleep there, and medications for sleep is one thing, and then a sleep hygiene assessment. A reasonably simple thing to do, difficult when pain is such a driver of poor sleep, but it's worth doing.
Absolutely.
There's no reason not to do it.
Because there could be some simple things there that the person didn't realise that could be big value adds.
Yep. And then back to mood control and associated psychological assistance through more specific strategies that you may use as a musculoskeletal practitioner through to referral to psychological assistance and maybe even psychiatric assistance in some cases. There's a whole raft of things around that are probably beyond our...
Yeah, but just to say, us educating and reassuring can help people's mood because they get a clearer plan. Engaging in exercise and getting function back can help with their mood as well. But if there's underlying significant mood issues, that's when on referral becomes relevant.
Yep. Mike Ryan, a friend of mine, always says physiotherapy is cognitive behavioural therapy. We just haven't called it that.
Yeah.
But what do? We give them exercise, but we speak to them and we find out about their family and we give them strategies around that. And so I think what we do is psychological management. We just haven't termed it that before.
Yeah.
I thought that was a nice way of kind of thinking about it. Okay, very good. So after that, we'll be able to get everybody better.
Good.
Excellent. Paper of the day. How's your Italian?
Well, I'm due to go there soon, so once I've come back, I'll have a go at pronouncing that for you now.
Yes. You'll be going, they're not locked down so much over there now, are they?
Well, maybe
You're not
not
going to
enough
attempt
for
it.
my liking,
Yeah,
we shall
exactly.
see. Yeah.
I got out of Italy at the right time, just when there was 4 or 5 people with masks around the airport when I left in January.
So you were lucky.
I was lucky. So a paper by Pete O'Sullivan, who's been a great source of inspiration and a mentor to both of us, I would say.
Yes.
So I've got a quote from this article, which is it's a great article around cognitive functional therapy and how the different aspects of that approach come together, and it aligns with what we've been speaking about. I'm going to give you a quote here, if I can read, around some attributes of a therapist to take on this kind of stuff, and it's an extensive list. So maybe as you listen to this, you could kind of think about, how would you start someone on this journey, or how would you help them on this journey to, mastering these things, if that's indeed their goal. So CFT, or cognitive functional therapy, requires specific skills across a number of domains, as well as contextual understanding of foundational behavioural psychology and neuroscience. These requirements can seem daunting for clinicians trained primarily to... I told you I couldn't read. These requirements seem daunting to clinicians trained to primarily consider physical and pathoanatomical factors and provide passive treatments for the management of disabling low back pain in this case. Communication skills are required to sensitively explore across the multiple domains and facilitate a strong therapeutic alliance, build self-efficacy, and promote behaviour change. Clinical reasoning skills are required to triage the individual patient and synthesize multidimensional data. Observational skills are needed to analyse functional and safety behaviours. Hands-on feedback and movement re-education skills are required to perform guided behavioural experiments and effectively teach functional behaviour change strategies. And confidence is required to discourage safety behaviours while reintroducing the individual to threatened movements or activities. That's a lot of stuff.
It is.
And but all very pertinent and aligns with what we were just discussing before. So what would you advise, the punter out there, in terms of, okay, I've just graduated from physio school, I want to go on this journey, because it is a journey.
Yeah, my first bit of advice would be to find a physio school before you start that's aligned to this sort of approach.
Yeah, you're assuming that's a very advanced student there if they're thinking about that.
Well, this is the changing
environment, is
it? It is, yeah. Darren, yeah. So I have some involvement in reviewing physiotherapy programs, and I've done some testing around this anecdotally in lectures with early undergraduate physios, where I've presented a case of someone with increased pain sensitivity following knee surgery.
An audit, Tim?
Well, it was an audit of sorts.
Yes.
And these were second-year physiotherapy students, and I threw up, why could this person not be able to bend their knee following the surgery? And all the different aspects that we've kind of talked about around their beliefs or their understanding or their confidence, and the students were readily able to list those off.
Right.
Which normally we do teaching in the postgraduate level, where it takes 12 months of training to get people to this level that Peter's talking about in the article there. So it's almost earlier to have almost a clean slate and not, I guess, be taught down pathways that we used to think that was how pain worked.
Yeah.
So that is a bit of a tough answer that I just gave.
No.
But we have to be open to understanding pain and how our system and different people respond to pain. So papers like that one you've quoted, that's one we'd strongly recommend reading for that reason, that you need to be able to step back and almost let go of some of the things you've been taught if you have been trained in a specific area, because it's having that broader understanding to be able to accept these concepts that makes you well placed. Because the other individual skills you're talking about, as you've read out there, physiotherapists are fantastically placed with the vast majority of those skills. It's often around the understanding and the reasoning that goes along with that, and improving our communication skills are the areas where we need to continue to advance what we're doing.
Yeah, good. And it kind of is a nice way to round out our series, although we do have one episode left. But it made me just again reflect on, look, I think every physiotherapist who's managing pain, it's incumbent that they could at least recognise this stuff. Whether they want to manage it or not is another question, and it's quite fine. If you don't want to encompass all these domains that Pete's spoken about, there's no problem with that. But don't see the person 50 times for acupuncture and think that that's okay.
Yeah.
Refer the person on, get some help, and everyone will be better off.
Agreed. You'll be happier. You'll be seeing the patient types that are best suited to your type of practice. Yeah. And because people that we get better make us look good and send us other patients, and the ones that we refer on, they're never unhappy about that. They're actually thankful to be directed to another appropriate area, and that's something most healthcare practitioners, but particularly physiotherapists in our experience, need to be better at doing.
Yes, correct. Great. So we're always open for questions, 24 hours a day on education@painoptions.com.au. And I know Tim gets up around 12:53 every night just to quickly check before he then goes to the toilet and goes back to sleep.
Just a quick check then, Darren. That allows me to plan a good answer overnight to respond first thing the next morning.
Very good, very good. So we look forward to your questions. But you got any questions right now, Tim?
It's almost toilet break time, I think, Darren. Where's the toilet?
That way.
Good.
Bye.
See you.